And I'm very happy to now introduce our last plenary session of the day. We're closing this day with a session being hosted in partnership with the Petrie-Flom Center for Health Law, Policy, Biotechnology, and Bioethics at Harvard Law School, as well as the David Rockefeller Center for Latin American Studies here at Harvard. To open the conversation, I'm delighted to welcome Sol Carbonell. Ms. Carbonell is the Executive Director of the David Rockefeller Center for Latin American Studies, and she has been a vital force in bridging these regional conversations across the university and beyond. Sol, we're honored to have you here, so please join me in the podium. Thank you.
Thank you for that kind introduction and for the invitation to co-sponsor this amazing panel with you. And in the meantime, if I could please have Alicia and the panelists come join while I say just a few words. It's really an honor for me to help transition the conversation to another part of the world, to Latin America, where our center is focused on. The David Rockefeller Center for Latin American Studies is referred to as DRCLAS. So if you haven't heard that before, it is incredibly confusing for the students when they get to campus and they are referred to see the doctor for all their interest in Latin America. But that aside, for the last 30 years, our center has focused on 4 primary pillars. First, we fund and facilitate faculty and student research in the region. Second, we create transformative student experiences in the region as well and on campus. Third, we host visiting scholars and fellows from all disciplines to come spend some time advancing the research here at Harvard. And last but not least, we promote public debate and conversations like the ones we are about to have today. For more than 15 years, we have also supported the field courses that the School of Public Health does in Brazil, in Chile, and Mexico. Last year, just to give you a quick example, through our internships, in Mexico City, we hosted students at the National Institute of Public Health, an institute focused on cardiology, and on another one doing research on pediatrics. And those are amazing opportunities for students. And through our Lehman Brazil Research Fund, we have also been able to support research on a range of issues, from infectious diseases to vaccine rollout to community health interventions, to name a few. And before I introduce our distinguished moderators and wonderful panelists, let me just offer 6 themes of the kinds of conversations that we've been having at the center just this month. And I'm not going to go into any of the details here, and just to set the stage. Number 1, increased polarization and far-right movements that have made it into power in Latin America. Number 2, shift away from multilateral organizations, diplomacy, and international cooperation, and move towards militarization and reorganization of international alliances. Number 3, increased misinformation, media segmentation, and echo chambers that reproduce biases. Number 4, low state capacity, not state size, but state capacity to provide effective and efficient services, including the provision of healthcare. Number 5, erosion of trust in institutions and strong public discontent. And obviously, number 6, the emergence of AI, which has a tremendous capacity to, of course, improve productivity and increase efficiency, while at the same time produce a vast amount of misinformation and demands an enormous amount of water use in a time where already access to quality and consistent water in Latin America is a real problem. So I wouldn't be surprised if some of these themes actually emerge in the conversation today. Personally, this topic is incredibly important to me, and is not abstract, because I am, as perhaps some people in the audience or those that are watching over Zoom, and one of those that has the personal experience of having to use the court system in Argentina through an amparo to be able to secure guaranteed pain medication during the last few months of my own mother's battle with pancreatic cancer. So personally, I want to thank you for your tremendous commitment to improve the healthcare system in our region and for your fierce determination to advance public debate on this. And with that, let me introduce our esteemed panelists and moderators. And I'm hoping that throughout the conversation, you can also give us some insight into the creativity, the innovation, and the resiliency that we see in our region every day. So with that, let me tell you who we have here today. We have Claudia Pesetto, who is the Regional Advisor of Evidence and Information for Health Economics and Finance at the Pan American Health Organization and WHO. We have Dr. Alejandro Gaviria, who is the former Health Minister, the Minister of Health and Social Protection and former Minister of National Education of Colombia, and Dr. Victor Zamora, who is the former Minister of Health of Peru and Professor of Health Policy at the School of Government and Public Policy at the Pontificia Universidad Católica del Perú, and Executive Director of the Gobierna Consultores. And our esteemed moderator is Dr. Alicia Yamin, who has joined appointments at the Harvard Law School and the School of Public Health and teaches on health policy and management and is a senior fellow on global health rights at the Petrie-Flom Center. So Alicia, thank you so much and welcome to all of you. Take it away.
Thank you so much. Thank you so much, Sol. And I hope we can touch on both some of the challenges that you laid out as well as the innovations, which are both technological and also social, I think we'll highlight. Because it's been a long day, and this is the first panel that we are having on Latin America. Some of this is going to be sort of explaining the very different sets of challenges and realities that Latin America faces. I want to start out by saying that it is an incredibly diverse region, diverse politically and economically and socially, but also in terms of the stages of epidemiologic transition that it's at. So there are challenges with NCDs, but there are still also very profound challenges with infectious diseases in areas of the region. And I don't want to erase or flatten that diversity when we talk about commonalities. It is a region that, in general, faces very steep socioeconomic inequalities and social fragmentation along gendered, racial, ethnic lines, rural, urban. And those differences and disparities show up in health outcomes, for sure, and are reflected quite acutely. It's a region of paradoxes with respect to health in many ways. There are lots of historically health justice movements from immigrants that came from Europe and were hoping to set up the same kind of universal healthcare systems that were in Europe and worked for social security systems and health in Latin America, to indigenous movements from Lázaro Cárdenas to the Zapatistas in Mexico, to a special brand of Latin American social medicine, the Brazilian sanitary reform movement that was absolutely critical in the transition from the Brazilian dictatorship into democracy and embedding principles in the Constitution, to the Green Wave for Reproductive Justice more recently that started in Argentina and swept across Mexico and Colombia and elsewhere. But on the other hand, it's also a region where the immigrants did not achieve universal health care in most places. There are segmented health systems. And it's very highly medicalized, despite the Latin American social medicine. There is, as Sol mentioned, a quite deep polarization and fragmentation in politics across many of these countries, as well as what, as a lawyer, I would describe as pretty profound regulatory and compliance gaps with respect to health as well as other areas. There's health systems around the region often stratify citizenship in a region which is already struggling with political inclusion. And yet, at the same time, I hope we'll also be able to highlight some of the great innovations and initiatives that have been taken, including by people on this panel. So with that, setting the scene, I think I'm going to turn to Claudia first and say, you have spent your career tracking financial health and stewardship of the health systems across the region. Could you give us a sense from your perspective, having worked at PAHO, of 2 or 3 of the major challenges?
Thank you so much, Alicia. And I would add to your introduction that also Latin American and the Caribbean is a region with great ambitions, great achievements, but also with great challenges. And this leads me to try to answer your question. And I would say that the first issue that we'd like to highlight is that one of the main challenges is the big segmentation that exists in terms of financing. And this was rooted in the uprising of the social health insurance movement back in the 60s that segmented the systems and segmented the population and also the access and the entitlements of different population in terms of who has access. If you are an employee, of course, you have access to a set of benefits and you go under and you can run under some rules of coverage as well. But it happened that model, that it sounds appropriate, didn't take into account the high levels of informality, for example, that persist in the region and have been developing and have been even deepening with the years after all the different economic cycles and challenges that have been faced. So segmentation it means that we have, along with the public sector, we have another share of the public sector that responds to a very specific group of the population, and that creates a lot of distortions in terms of inequalities to access, and also on the quality of the services that people have access to. Fragmentation is also mirroring this situation in fragmentation of the health services themselves, how health services are organized, that correspond to this segmentation somehow. We had these social health insurances models focus more, for example, on specialized care, whereas primary care, which is mostly concerned on prevention and promotion, has been derived to the public sector themselves. That's one of the issues. The second one is, and that stands out in the region, is the lack or insufficient public investment in health. And as we are ambitious in the region, we also set very ambitious goals. For example, in 2014, the countries or member states approved a resolution in PAHO to increase public health investment to levels of 6% of the GDP at least. Well, this hasn't happened, of course, in 2023. And after a spike during the pandemic, but in 2023, the levels of public health investment are around 3.8% of the GDP, which bring us back to the levels of 2019. There are variances in between. There are 4 countries that have, 3 countries in 2023 that have only achieved this goal, Argentina, Cuba, and Uruguay. At some moment, there were even 6 or 7. And along with this, the reflection of this lack of investment is the increase on out-of-pocket payments. There is a clear correlation between public investment in health and out-of-pocket payments, because if the public sector doesn't have the capacity to offer or to meet the demands of the population, obviously the demand and the needs are there, and they somehow need to be attended, right? They need to be met, and people tend to have no other option than going to the private sector. That's what generates out-of-pocket spending that has been increasing slowly during the last 2 or 3 years post the pandemic. The third factor, and I'm gonna stop that, but I think it is important because of the discussion related to governance, is that in Latin America we have this variety of centralized and decentralized states. So this segmentation also in terms of how the health financing system is organized in terms of entitlements, social health insurance, etc., has also another bucket of segmentation that is related on how the public funds are generated, are allocated, and are used. Because in those countries where the regions have or are decentralized, or the central power is decentralized to the regions or to municipalities, it also creates even more dysfunctions that at the end of the day impact on how the public funds have results or have a real impact on outcomes in health.
Great, that was a super helpful overview. Alejandro, can I turn to you, because Colombia in many ways has experimented with and achieved quite a lot in terms of addressing segmentation, out-of-pocket costs, and other issues related to financing. So could you talk to us about what Colombia has done and how it did that?
Okay. Let me say first that Latin America has been called the forgotten continent. And we share some of the problems of the African continent that we discussed this morning, but we also share some of the problems of the global north that also we mentioned today. And Colombia, in a way, summarizes that. If I have to pick a headline to explain what happened in Colombia over the last 3 decades, I will pick the cost of success. Is a contradictory, paradoxical, even tragic story. It's a story of social progress and a story of paralysis that we are seeing now. In the early 90s, Colombia was in a very difficult situation. The Colombian democracy and the Colombian institution, the Colombian society was threatened by terror and violence. And Colombia, my country, responded to that with more democracy, with a new constitution in 1991. And with this constitution, we have a wave of reforms: the fiscal reform, the centralization or decentralization reform, and social security. And we created an ambitious health system based, Alicia, on one idea: solidarity in the finance and equality in the benefits. And we achieved quite a lot indeed. We reduced out-of-pocket to 15%, out-of-pocket payment, 50% of total health expenditure. That is the same level of a typical OECD European country. In Latin America, the average is over 30%. For some diseases, say chronic renal disease, Colombia now has 40,000 patients, and they receive very good quality, specialized care, zero copayment. The reform invited the private sector. We have private providers and private insurance companies cooperating with the Colombian state, and that was controversial from the beginning. But that created many capacities, social capabilities. And also the reform mandated a substantial increase in the budget. But now we have strengths, we have problems. And the first one is the financial problem, the financial sustainability, and we'll talk about this a little bit later on. But now the deficit of the Colombian system is about 1% of GDP, of the Colombian GDP. So it's a huge one, and it's increasing. And also for the last 3 years, the health reform in Colombia has become a battlefield of an ideological war. And the health system is deteriorating rapidly. And we know that health systems don't go bankrupt. They adjust against the people, and people are suffering. And this, Alicia, is sad. And the country is destroying some of the capabilities that we built with much effort over the last 3 decades. That's the situation now.
So, Victor, can we turn to you? Because I don't think the slogan for Peru would be the cost of success.
No, it is not.
So maybe you can walk us through a very different scenario in Peru with a lot of political turbulence and a lot of fragmentation.
Well, thank you very much for the invitation. And I would like to build up on what Claudia has mentioned. She has mentioned fragmentation, segmentation, decentralization as 3 facets of characteristics of our health systems in Latin America, which we have in Peru as well. But I would like to mention 3 different ones, which I think are relevant. One of them is chronic underfunding, especially for Peru. 3.5% of the GDP, which is the GDP of Peru, it's a very poor country in terms of investing on health. The second aspect is corruption. Corruption undermines the health system in general. But it's not proper to the health system, but also for the entire society in Peru. And finally, I would say during the decapitalization of human resources doing the managerial work, And that's a result of what you have mentioned, fragmentation. But fragmentation is, second, it's not an aspect that we have to take into account only for the health sector, because it's deeply rooted in the history of Latin America. It's a result of clientelism and paternalism in their relation with the state. Those who have the power, those who live closer, they will have their own health system. And finally, fragmentation is also it's an attempt. I mean, I am surrounded, as in the ministerial cabinet, by a lawyer and 2 economists, and they look, especially the economists, from the efficiency perspective. You cannot be fragmented because the costs of transactions is very high. You can get more out of, which is true, more out of the same money. But looking from the human rights perspective, fragmentation is a threat, because the constitution in Peru establishes that we are equal, and we are equal according to the equal. Every Peruvian is equal. How would you say equal in the law? Yeah. And secondly, that we have the right to health. But since we are living in a fragmented world, our rights are also fragmented. Our citizenship is fragmented from the human rights and health perspective. We are not equal in terms of health care, health access, health benefits. So from the human rights perspective, fragmentation is a major threat, and we have to deal with it. Let me just put some figures to get you closer to the Peruvian reality. We have 5, in general, 6 systems, national systems. First, the Ministry of Health system, which is financed by taxes. The Social Security system, which is financed by those who are employed. Those who are employed are about 30% of the entire population, and the rest, 70%, is informal or not have a job at all, very poor people. Then you have the Ministry of the Public Financing, the health system for the army forces, which are three: naval, Air Force, and And then you have the health system for the police forces, and then you have the health system for the judiciary system, which is take responsibility for the healthcare of the prisoners, and then you have the private sector. You have to multiply those by 25 regions, and you have 4 or 5 funds. You can cross those lines, and you can imagine how difficult it is to manage that system in general, how difficult it is for a person to navigate in such a difficult environment. It's paradoxically, we have our big brother Colombia, which has taught us a lot during these years. Paradoxically, during the last 15, 20 years, we have moved from 50 to 60% of people who have an insurance to 97% or 98% of the people living in Peru that formally have an insurance, a health insurance, including our visitors from Venezuela. They are included in the health insurance. But one thing is to legally have an insurance, but a very different story is to have healthcare, in the system. Because it depends on what type of insurance you have, what type of healthcare you get. Being the Ministry of Health, the most the most fragile system in terms of delivering care for those entitled to. So if you have fragmentation and the capacities of the government to implement a health insurance, what is the response? Fragmentation is a major threat to the right to health in Peru. Fragmentation. It's not an efficiency aspect. It's a human rights perspective, and we have to look after.
I agree. So I actually want to follow up with you on some of the things that you brought out because, as I think Sol mentioned and I mentioned and a number of us have mentioned, political polarization. And health really is deeply political, even if we fool ourselves into thinking that it's just a technocratic undertaking. And that could not be more clear in Latin America. You in Peru, there have been 10 health ministers in the last decade. We are right now today going through sort of the last election is kind of finishing up. We don't know exactly who the president is going to be, but we have an idea. So I wonder if you could talk about being Minister of Health, and you were Minister of Health when the COVID pandemic began, and how the politics influences your ability to carry out your agenda.
Well, health is political. Health reform is political. Being Minister of Health is a political task. But in Peru, you are not counting well. During the last 18 ministers of health since 1915. Since 2015, we have had 18 ministers of health. And during the pandemic, we had 5 ministers of health.
During the pandemic?
During the pandemic. 5 ministers of health,
Oh my God.
3 presidents, 2 Congress, 1 election, and a huge protest during the pandemic. So you can imagine how political is the scenario. Well, that's an extreme situation, I would say. Having said that, considering health as a political issue should not be, on the contrary, consider that health should be politicized. Politicized in the way these organizations, all of the I have mentioned already, is being used for clientelistic purposes, corruption or whatsoever. Politics is damaging the health reform or any modernization of the health sector in Peru, because politics is not transformed into institutions. So everything is short term. We cannot think in long term perspective. We have lost the long term vision of what we want to achieve in Peru. We have made some efforts. Health insurance, the national public health insurance, has been created and developed and still maintained, even when everything has changed. 18 ministers and the health insurance still running and increasing little by little. We have to look after these kind of successes in the middle of the chaos. You know, we have reduced undernourishment from 30% to almost 10%. We have increased health facilities for mental care at the community level. Something is happening in between. In that chaotic environment, there are some things that are happening, and we can show to our neighbors, to the world. But I think that eventually, if the situation calms down, we can do much better than what we have done now.
So Alejandro, the situation in Colombia when you were Minister of Health, and you were Minister of Health for the entire period of Santos?
For half of the first period and the entire second period.
And for the entire second period.
6 years, I've been the longest serving Minister of Health in the history of Colombia, for better or for worse.
But you were also Minister of Health at a very interesting time, because not when a judgment, in Latin America, there are many countries, including Colombia, where the right to health is a constitutional right. And there had been an increase in judicialization of the right to health, so that there had been 700,000 tutelas or protection writs by about 2008. And the Constitutional Court issued a major structural judgment that called for the restructuring of the health system. And thereafter, you became Minister of Health, and were dealing with a lot of different political forces at the time. And how was that, to navigate that?
I'm going to tell you that, but let me first say something strange about this thing is political. When I was appointed Minister of Health, I was an academic. I was the Dean of the School of Economics of the University of Andes in Bogota. And one day the president called me, and he asked me, "Do you like challenges?" And I say, "No."
Was suspicious, right?
And I finally accepted, but was not a political appointment. And the reason for that was political economy. The system in Colombia is complicated that he didn't understand anything. And he basically told me, "Take care of that." And I realized pretty soon into the game that I have a lot of leeway to make decisions, but he was supporting me. And that's why I was minister for so many years. And one of the problems was the sentence, the judgment, how do you call it?
Judgment, sentencia, judgment.
Sentencia, yeah.
T-76008.
Colombia is a country
You
of
also remember.
lawyers, and we have this thing that we memorize the numbers of the judgments and the numbers of laws. So everybody in Colombia familiar with the system know the T-760. T-760, that's the judgment. And I read 500 pages of the judgment without a spelling mistake. Perfectly written, but problematic. That sentence, Alicia, that judgment, didn't have a reflection about the ethical consequences of creating a very open system with everything, every technology, every new medicine was in theory included. Didn't have a philosophical reflection about this tension between a utilitarian sort of view of health and the Kantian or deontological view. Everything was included. Rule out that judgment, rule out any form of priority setting. So I have to deal with that. And I decided to fill that void. So the Constitutional Court had decided not to give that debate. And I decided to create a space for that conversation. Our life is complicated. In June of 2017, I was diagnosed with cancer. And I had this ironic coincidence of being Minister of Health and cancer patient. And you know what? I took advantage of that opportunity to put into the discussion these bioethical dilemmas. And I wrote a letter to the public saying, I'm going to be treated in Colombia with the same basket of benefits of any citizen. And that created a debate. And that changed the situation a little bit. And we have had since then interesting and difficult discussion.
So I have often thought, I'm going off script here, but the justice who wrote that opinion,
Manuel José
Cepeda, left the court within 6 months. And at that time, you were not Minister of Health, but then shortly thereafter you were. And we, in academia, like to talk about different structural forces, et cetera. But after really studying this judgment and the after effects for many years, I often have thought that if you two were in your positions at the same time for enough years, that things would have turned out very, very differently.
He taught me something very powerful, a sentence. He taught me, we have to be able in Colombia within the society to collectively construct a no, how to say no in a health system in a legitimate way. And we still don't know.
So Claudia, can I turn to you with your regional knowledge? And there is a lot of political turbulence. Every time a new government takes office, priorities may shift in terms of health. Sometimes advances are paused. Sometimes there is an entire reversal. So, after your long career and decades of working with different governments, how do you manage that? How do you manage?
I'm not that old, Alicia.
No, go on. That's my decade.
It's okay. But first of all, before I answer your question, I want to tell Alejandro that we as economists are supposed to be the worst ministers of health ever, because we always start saying any discussion saying that resources are scarce. And a medical doctor and public health people, medical doctors say, well, I have to save lives. It doesn't matter how much does it cost. And public health people, well, we have to meet needs of the population. So there's a conflict there, and you are not the only one on the back. And from the regional experience, one of the most successful reforms that are happening in the region has been the one in Uruguay, and surprise, surprise, it was led by an economist, while a Minister of Health was an economist, Daniel Olesker. And, but anyhow, and just to answer your question, Alicia, and piggyback also on the example on Uruguay. Uruguay also has the same problem of judicialization as Colombia has, as Argentina has, as Chile has, Brazil as well. And in Uruguay, it has arrived to the level that it has been very relevant. Because, for example, last year, the amount that was paid through judicialization causes was equal to 51% of the budget of the Ministry of Public health. So this means that it's being spent more on that than on the regular operation of the Ministry of Health. How this has been, and I'm putting Uruguay as an example because I think it is one of the health systems more successful in the region, together with Costa Rica. This might be very debatable, and some other country might say, no, my system is also successful. But I think in terms of sustainability and the achievements and health outcomes, I think Uruguay is a good example. I just lost what I was going to say. But it's not the only place. The way that they were able to deal with this amount of utilization has been to opening the floor. I mean, bringing all the actors together, and I think this is the recipe that might be successful. You have to open the discussion, because priority setting in a context where the right to health is ingrained in the Constitution, it requires also that the social contract gets involved, right? And that everybody needs to have a say on that. And that's not easy. That requires leadership. It requires experience. It requires openness, to listen and to come up with a solution that is going to be for the benefit of the society. Because in every negotiation, there's always losers and winners. The trick is to make the losers think that they are not losing that much, that they are winning a little bit, even though they are losing. And I think Uruguay has been very good in doing that, and I think this should be the way to do it. Bring in the academia, bring in the people in charge of the technologies evaluation. I mean, those that tell or that say decide which medicines, for example, are going to be guaranteed or are going to be part of the package of benefits or not, or also people from the constituencies, right? People from the Congress, specialists, economists, everyone together, even the private sector, because most of the causes of judicialization are related to either high-cost treatment or high-cost medicines. I mean, high-cost treatment is related to high-cost medicine. So the industry also has a say on that. And I think it is the way to go out. It's inevitable, at least in our region, that we are going to have this swinging between different visions on how a country should go. We have more left-sided, let's say, although it's kind of relative now, but more to the right, more to the left, or to the center. That's inevitable. But the vision of the country, at least there must be some consensus. And that goes through a strong social contract that is built up on the basis of dialogue. I think that would be my answer.
Okay, I'm actually going to go to you about T760 in a sec. Can I just set you up? So I will say, we all have different perspectives on this phenomenon of judicialization. I'm a lawyer, and I've worked on it from one perspective. I was appointed by the Colombian Constitutional Court, and I've worked on it in Argentina and elsewhere. I think judicialization should be understood more as a symptom of problems than as a cause of problems, and a symptom of many of the things that have been mentioned. The fragmentation of the system that makes the setting of cost-benefit thresholds impossible across the board. The regulatory and compliance gaps that allow for enormous gray areas, the lack of priority setting, the lack of pharmaceutical regulation, which actually, I'm going to come to you now, Alejandro, because you were very active in addressing that. But I wouldn't want us to walk away thinking that the judicialization of health rights has been unequivocally bad. The T760 decision itself was a response to individual litigation that had become just unmanageable. And it was a dialogical judgment. So it didn't say the right to health means XYZ. It deliberately threw it back on you in the Ministry of Health and Social Protection to say you need to adjust the contributory regime and the subsidized regime, fix the reimbursement schemes, and a whole lot of other things. So I'd love to hear your perspective of having gone through that period.
Alicia, I think judicialization is both. Is a symptom that this fragmentation and problems of the system, but also is technological pressure, is the new innovations and so on. If you look in Colombia, the geography of judicialization, you're going to find something that is paradoxical. It's in the main cities and in upper middle classes where you find more cases of judicialization. That is...
They can pay the lawyers.
Yeah,
tells you something.
a lot.
Let me tell you another anecdote. I have almost every other month a conversation with the leader of a pharmaceutical company in Colombia. And we are together for lunch. And I always ask the same question. Where have you been? And he or she tells me in Brazil, in Peru, in Mexico, in Colombia. What do you think of the Colombian system? Oh, it's the best. And I'm worried because this very open system has been very good for the pharmaceutical companies. And the technological pressure is probably the main cause of the fiscal and financial problems that I described. Let me go back to the numbers of judgments and laws. So we have T760. And after T760, the judgment, came a law, and the statutory law. It's 1751. So in Colombia, everybody knows the T760, and everybody knows the 1751. And the 1751 was a way to incorporate some of the mandates of T760 into the law. And we created some exclusions. And I spent almost a year in Congress trying to do some educational sort of work, telling to senators and representatives about these topics. And the Colombian Congress made this decision, say, no reasons of cost benefit can be argued to exclude a technology, medicine, or anything. Only what is experimental, but doesn't have any evidence, can be excluded. And that's complicated. Especially in modern medicine, where you have this tension between value and price. So it's impossible in Colombia now to say, no, you have this new cancer medicine. It's associated with 1.1 months of overall survival and cost 3,000, 4,000, 10,000 per month. You cannot say, for reasons of price, that's going to be excluded. And that's complicated. And
I agree with that. Right.
I have continued participating in the public debates about health reform in Colombia. And every week, I get a message in social media. Somebody telling me, you were minister for 6 years. Why you don't solve these problems? Why you didn't solve these problems? And my only honest answer is they don't have a solution. You have to manage them. You have to do a lot of stuff, and I'm going to describe in my next intervention what we did, just to maintain this precarious position.
Well, Victor, Peru is a very different scenario.
It is.
There is not the same kind of judicialization at all. So we'd love to hear your perspective from, a ministry in a country where that is not so much of an issue.
Well, I would like to warn the audience that not having a judicialization process should be understood as a romantic place where there is no problem. There are no problems. On the contrary, silence speaks a lot. Why we don't have a judicialization process in the size or with the impact that Colombia has had? I think one of the reasons is that to navigate the judiciary system in Peru is quite difficult for any person. It's very costly. So very few can afford to navigate in the judiciary system. Secondly, it has to do with citizenship, quality of citizenship. I don't know if you have met Sinesio Lopez, who is a sociologist who has written a book about the types of citizenships that are in Peru. He mentioned you have high citizenship and low level of citizenship. When you know your rights and you can exert your rights, it's high level of citizenship. When you don't know your rights and you do not exert your rights, you have low level of citizenship. So you can imagine the majority of Peruvians do not know their rights, and they do not know how to exert the rights, and they don't have the means to exert the rights. So it means low levels of cases will reach the judiciary system. Thirdly, what you can achieve. What you can achieve in terms of it's case by case. It's not those who reach the judiciary system and eventually have reached a positive result. It's just case by case. It is not transformed into a policy or a law. It is just case by case. Eventually for HIV patients, but that's not the norm. The norm is case by case. It's costly. It's not in the rural areas, so the judiciary system is far away from the regular Peruvian citizen. Fourthly, there are some other mechanisms that have been developed, parallel mechanisms. Within the Ministry of Health, for example, the Superintendency of the Health, it has been created on the purpose of protecting the rights of the people using the health system. But since it is appointed by the Minister of Health, the superintendency does not exert they do not fulfill their role as correcting the errors in the system, because it's politically appointed by the Minister of Health. So there are problems there. And finally, during my tenure, I have created the Center for Health Technology Evaluation and the National Institute of Health in order to have a clear path, a very transparent one, to choose which technologies can be supported by the system. Those two are very weak. They are on its infancy. But I think if the judiciary system is not the right tool to use, we can develop some others in order to fulfill the right to health for the Peruvians.
So perhaps I should just explain for those of you who aren't familiar with Latin American laws. So many of these when we say how many lawsuits there have been, the protection writ is extremely easy to use. So in many countries, including Colombia, you don't need to even have a lawyer. So for people in the United States, it might be more akin to saying, a complaint with your pharmacy benefit manager, right? It's not the way we think of litigation in this country, and that's why the numbers can seem astronomical, right? So so the legal opportunity structures are very, very different. That is not the case in Peru, and that explains quite a lot of the difference. But in Argentina, in Brazil, in Colombia for sure, and to some extent in Mexico, and in Costa Rica, in Uruguay, in Chile, to some extent that is the case. So we are now moving into the last segment before we open to questions, and it's really sort of about regional governance. We now are moving into a new kind of multi-level multilateralism. Latin America is not by any measure, stretch of the imagination, aid dependent in the same way that some of the other countries and the region of sub-Saharan Africa is. So, but in Latin America and in the Americas, the US and Argentina famously have pulled out of the World Health Organization. So I guess I would turn to you, Claudia, to say, what is the role of PAHO in this new world order?
The brave new world.
Well, I don't think the role has changed. It just has evolved, but it hasn't changed. It's in the mandates. It's in the constitution of PAHO, which is previous to WHO. We love to say that. I know if Calypso is still here. We love to say that we are older than you. But anyhow. I just would like to focus on what we have been doing from the Health Systems and Services department, where we have been, which I belong to, and I think the idea has been in this era of less resources, less financial resources, we're trying to emphasize the way of how to strengthen experience sharing. And put countries together on one side, creating different networks on the essential public health functions, on how to better manage health services through integrated health services networks, through a group of national health funds and where they function in the region. So trying to find ways and scenarios where the experience sharing can be strengthened, and where the good lessons could also be drawn from, right? And in the other hand, what we have been trying to do is to promote, and in order to respond to the lack of public investment, we are conscious that the macroeconomic and macro-fiscal outcome in the region is not too promising, right? So we need to try to create or enforce the consciousness that the few resources that we do have is what we are going to have to work with, while we still do advocacy for increasing fiscal space in many ways. But also the need to better use the scarce resources that we have, and to how to improve efficiencies, and there are still many ways to do it. We are also working hard with the development banks, with the Inter-American Development Bank, and also with the World Bank through an alliance for primary health care, where the idea is trying to put our forces together to avoid duplications, those duplications that were mentioned earlier in the morning session, for example. Those also exist in the region, and at the country level, they can become very complex because you have different funders sometimes trying to work on the same topic and with different checks and balances for each of those funding sources, so it becomes very inefficient. So the idea of the alliance, for example, is trying to put them all together, sit them all on the table with the ministries of health, sitting, when I'm saying all, I'm talking about the World Bank, the IDB, and PAHO. PAHO doesn't fund, but we provide technical advice with the ministries of health and trying to come up and to coordinate the agenda to make a better use of the resources. So I think that's the best way that we are, the way that we are trying to strengthen now. And I think we're being quite successful. We have some countries that are adhering to the alliance. I think so far it's six or seven countries already, and they are working on more. And we hope that this is going to be effective, and that the changes of government will not affect this compromises, right? And or commitments. I'm sorry. And it's a way to ensure sustainability of what we do, as it is also created evidence. Something that we lack in the region is that we have great policies, we have great regulations, but we don't have the evidence of what works, what doesn't work. And I think that is important, because that's the way that you can guarantee impact, and ultimately you can guarantee sustainability, right, in the long term. And it might be a way also to shield some policies, right, and to shield them from these swings that we were talking about earlier. Because if things work, there's no way to dismantle them, right? At least in theory. We have seen weird things lately, but it's a way to ensure sustainability of the things that really work. And I think one of the big challenges of health systems is that they are evolving. Nothing is static, right? Everything changes. The epidemiologic profile is changing. The demographic profile is changing. The pandemic gave us big lessons that, as Sania, she portrayed it very well. She described very well. Now everybody is suffering of collective amnesia about what was learned from that, right? Nobody wants to talk about it. And I think there were very good things that were done in that. And we have taken the way to highlight some of the things, the well things that were done. For example, digital health, now artificial intelligence, and so on, which are very useful. But there are also some other things at the root that need to be fixed in order for those advances to work well. For example, the quality of the data. It is important. We can have interoperative information systems, but if the quality of the data is not good, we're going to end up with any result. So there are many things at the basis that still need to, we're trying to leapfrog from paper doing to artificial intelligence without, and that's my concern, without having fixed in the middle, right, in the inputs. So we'll see what happens in the following years. But I mean, we are at PAHO. We have the advantage that we are present in almost every country in Latin America and the Caribbean. We have offices in most of the countries. In Latin America, for sure. In the Caribbean, we have some regionals, etc. But and I think that's the best way to ensure that things, because. And this is not like a propaganda or merchandise. I'm just trying to explain the value that PAHO has in terms of the continuity of the value of the what the things that have been achieved, right? Even though the government officials change, or the orientation or vision of a determined government changes. So, yeah. Stop there.
Right. So Alejandro, can I turn to you? You said you had told these people that you hadn't found the solution because there was no solution, but looking ahead, what would be your priorities for the Colombian health system, and what are some of the possible risks or challenges facing Colombia now? You have an election coming up.
Yes, we have an election, May 31st, presidential election. I met last week with the president of the Constitutional Court, and we had a very interesting conversation about everything. And I saw, Alicia, that probably there is a convergence. A consensus is emerging in Colombia, for example, about the importance of priority setting. And the civil society, Physicians Association, the academia, Constitutional Court are working together despite political polarization. And this is good. And I don't know if I have been a little bit like cynic, but I believe in that we need a bias for hope. I want to call it that way. That we are not going to solve all the problems at once, but public policy can make a difference. And as I mentioned, I regulated prices. I did something crazy. We did a compulsory license for medicine for reasons of price. And I don't recommend this. It was a tremendous battle. But we advanced.
And he got a lot of pushback from certain people in the United States.
I got a letter from Joe Biden. He was then Vice President of the United States, saying that if we continue with this, they are going to suspend the help for the peace process at that time. I don't know why I wasn't fired, but something happened. I think it's also important to say that if we see convergence of health outcomes, the story of Latin America has been impressive. And I want to be a evidence-based optimist. There are many things that we can do. And yeah, political polarization is an obstacle, but we are still working together. And I was for some years also president of a university, and almost every day I used to say the same. We have to connect more with civil society, with government, and working together. And this is what we're going to do. Yeah.
Can I just add one thing?
Change the world. Yeah.
This is not a promo for Alejandro, but we haven't talked a lot about social determinants. And one very important measure that he took as Minister of Health was to ban glyphosate. Now, glyphosate in Colombia is obviously hugely important to the drug war. So there was a lot of blowback on that, too. And I think it took enormous courage and integrity. Maybe you just want to say a word about that, too?
Yes. Glyphosate was used for spraying coca fields. And we started accumulating evidence that this was related to all type of health problems. And one day, I went to see the president. And I told him, look, the evidence we have, including everything is connected. Some evidence of the effect of glyphosate in non-Hodgkin lymphoma, the one I got. I was not sick then. This is how life connect with many things. And the president told me, I want to make that decision. And we made that decision. I didn't ask anything. And was a huge battle inside the government. And since then, glyphosate is not used as the anti-drug policy in Colombia. And that was a victory for many communities in the periphery of the country.
Yes.
Okay, so turning to you, Victor, what are the hopeful kinds of signs of innovation in Peru and possible also challenges that you see coming down the pike? You've just had an election. It's also a complicated political scenario.
Well, we have to close the gap. We have a lot of debts in social terms. That's one of the main challenges. We still have tuberculosis. We still have plenty of people living in zones affected by malaria, dengue, and some others. Another challenge dealing with the new epidemiological profile and demographic profile. We have challenges including in our health system, new technologies, and financial challenges, as everybody. So the challenges are there. But we are not going to be successful dealing with those challenges if we do not take into account the lessons learned during the pandemic. And I will share with you 4 of my own reflections. Being a very weak health system, you can see the figures everywhere about how the performance of the Peruvian society during the pandemic. And I think it summarizes in 4 lessons. First one, and this is something that PAHO, IDB, and some others will have to take into account, especially in these times. First, we need more state, stronger state. It doesn't mean a larger state. It means a responsive one, a state that is present where now is absent, totally absent. And it calls for more money, more people, and a lot of things that we have to discuss in terms of the presence of the real presence and effective presence of the state. Secondly, we need more evidence. As mentioned here, a very beautiful story. The evidence should be highlighted as a main tool for decision-making process. Even though we have a political turmoil around us, evidence should play a key role in the decision-making process. Thirdly, more ethics is needed for public policy. Ethics is very key. I'm talking about during the pandemic, Vacuna Gate, public officials during the pandemic vaccinated themselves, you know all those stories. Among others, the private sector using their power in the market, selling drugs at high-rocketing prices and everything. So we need, as a society, more ethics. Unfortunately, do not forget about social justice. When we started in Peru the vaccination against COVID, in February, between January and February 2021, it was quite a success. It was quite a success. You remember me, the times when we were vaccinated against polio, sarampion, America Latina, champion of vaccination. It was beautiful. 1.5 years after we started vaccinating by COVID, the vaccine reached the native communities in the jungle. 1.5 years after. And not because of lack of money, lack of political will. Those are left behind always. So my 4 lessons that I would like to share are those: more and stronger state, or ethics, the role of evidence, and fourthly, do not forget about those who are always left behind.
Systematically. Those are great lessons to end on. We have a few minutes, so I'd love to invite some questions. Joya?
You want to start with the...
Oh, yeah, sure. Let's start online, Princess.
So we have one question online, and they asked, given the care system strengthening strategies presented under Inter-American Development Bank's IDB Cares initiative, how do you see these reforms contributing concretely to improved pandemic preparedness and response capacity in Latin America and the Caribbean?
Maybe Claudia, that's for you.
Oh, yeah.
was thinking it was more a question for you.
The Inter-American Development Bank play a very, very important role in the implementation of the Colombian health reform for 20 years. For the pandemic, I don't know.
Me neither.
What happened after that?
Me neither.
I mean, actually, honestly, I'm not familiar with the details of the strategy, so that's what I prefer to refrain to comment on it.
Well, no, in my case, I think they are approaching the right agenda. Because what we have said already, we have advanced in terms of financing coverage, some more, some less, but we have moved from what we had before. But having legal status or having a health insurance, it has to be accepted. And it has to be accepted at the primary healthcare level with health networks. So I think the IDB is targeting rightly, to strengthen the capacities of the state at the basic level with health networks of care, which is from my perspective, is the right way to start this long road.
Muchísimas gracias. Trabajo en Perú con socios en salud.
Okay.
Me gusta mucho Perú. My question is, I think Latin America, in a very different way than Africa, has just very, very profound economic inequality. And how do you think of this economic inequality as a driver for some of these health outcomes? And I particularly reflecting on the real devastating consequences of COVID-19 in Peru, and how much of that do you think is driven by economic inequality, and how does the health sector work across Latin America to try to address that disconnect?
May I?
Yeah, please.
I wouldn't say that it's only economic inequality, it's also social inequality. It's a mix of social and economic inequalities. And I must say one of the best evidence that we have from a health financing point of view is that in terms of financial protection, the latest numbers that were published on the Global Monitoring Report that monitors all the SDG indicators and the 3.82 indicator specifically on financial protection that was revised. Some of the evidence shows that the poorest households are those who face the largest financial difficulties in terms of financial hardship, as it is defined by the financial protection indicator. The majority of households with excessive or catastrophic spending became impoverished. There's also an ample variability in terms of the number of households that suffer of financial hardship for having to access health services, and it goes from 3 to 35 out of 100 households. So there is a lot of room for improvement and a lot of policy design that needs to be applied in the region, and this is as I was trying to portray from the beginning on your question. It is a reflection of the inequalities, let alone the people that do not access the services, because you measure financial protection when the people access the health services, but we don't know who don't have access to the health services. So I think that's and the other, I think there's another piece of information that is very important, is that mostly households fall into catastrophic health spending or excessive spending, as it was redefined, because of medicines That's the main cause of catastrophic health expenditure. So, and we haven't resolved the issue yet. If we observe the out-of-pocket expenditure indicator by itself, which is kind of the cost of financial protection, you will see that the trend, it's starting to spike up again after the pandemic, unfortunately. And everything has been treated or tried. But
Do you have any last comments on that?
Well, very brief. I think we are measured wrongly in terms of our development. I'm saying this because Peru is considered not only because of its food, but also because in economic terms, we are considered the star of the region. You know, low inflation, low fiscal debt, and the final one, I don't remember, but there is a third one. It's a financial indicator. Growth. Growth. Yeah. The most important one.
Economic growth.
The three of them, check. Very good. 30% of the people living below the line of poverty, and extreme poverty, and sleeping tonight without proper nutrition. So, food insecurity. I think our status of health is wrongly measured in economic and financial and social terms. And the indicators that we use on health are not sufficient to have the entire picture. And secondly, in terms of social protection, financial protection, going back to your question, PAHO and IDB should stress the need of supporting supranationally, internationally, public goods. Yes. Public goods. That was one of the key management lessons out of the pandemic. The need of an infrastructure that supports the country for public goods and to provide at least a responsive state during an emergency. Even responsive, not preparedness, proper response to an emergency. It could take hours, but those are the two things I would like to share with you.
So I would love for all of you to join me in thanking our incredible panelists.